That's a very exciting topic at the moment because we're seeing the first trials that specifically try to treat patients with clonal hematopoiesis or clonal cytopenias. And I guess you can largely split these treatment approaches into two large fields, if you wish. One are genotype-specific approaches, where we try to use targeted substances, inhibitors that are specific to certain genetic lesions. For example, we heard Eitan Stein talk today about IDH mutations in low-risk MDS, and there are also trials evaluating those in clonal cytopenias. Or we have spliceosome inhibitors. The advantage, of course, is that we would expect these strategies to directly target the pathogenic clone. On the other hand, since many of these mutations are relatively rare, those approaches are only applicable to a small subgroup of patients for each treatment. The other big group of approaches is therapies that target the microenvironment, that target downstream consequences of clonal hematopoiesis. For example, the pro-inflammatory state that is associated with many of the CHIP mutations. An example would be canakinumab, an anti-interleukin-1 beta antibody, which tries to target the CHIP-associated inflammation, and thereby it may help to avoid downstream consequences of CHIP, but it may also affect the fitness of the CHIP clone itself, and thereby also affect the clonal disease in itself. It's very exciting to see these different approaches and these different studies underway, and I'm very curious to see which of these approaches will be ultimately successful in the clinic. I want to add one little caveat, which comes from Michael Sekera's talk on del(5q) MDS that we heard today. We carefully have to design what the relevant endpoints in these trials really should be. Because, for example, if you have a patient with clonal cytopenia and your endpoint is to delay transfusion dependency, then this may be advantageous to the patient. It may improve their quality of life. It may reduce their symptom burden. But you're also potentially exposing patients to side effects. And you could use the same drugs potentially later if patients progress and become transfusion dependent, for example, and you could start the same treatment at that point of time, at a later point of time. And if in the long term, when it comes to long-term disease progression and patient survival, the early intervention is really going to be advantageous, is something that remains to be carefully studied, and we have to wait for those data too.